Good afternoon, everyone. Thank you for joining us today in the second and final day at the Lymphoma Canada conference and for attending this panel discussion on unmet needs and challenges with lymphoma treatments. While we're all joining in from different locations today, the land I'm calling in from is the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. I am grateful and indebted for the opportunity to come together on this land, acknowledging that Indigenous people are the traditional guardians of this land that we call Canada, and realizing that land acknowledgement is only a first step in the essential act of reconciliation with Indigenous people. I would like to begin by introducing myself. My name is Sabina Vorha-Miller, and I have been involved with Lymphoma Canada for over 5 years now, starting as a volunteer and now serving as the vice chair of the board. I'm absolutely thrilled to be your moderator for today's session. So we have an incredible panel for you this afternoon, and it's my utmost pleasure to introduce them. We are joined today by two patients, Christina Ronio, who for many years has been a member of the Lymphoma Canada Patient and Family Caregiver Committee, helping Lymphoma Canada develop educational and support programming by providing a young person's perspective. Welcome, Christina. We're also joined by Alison Moray, who we have had the pleasure of working with and speaking to through support groups such as the Southwestern Ontario chapter. Welcome, Alison.
Thanks.
Lastly, we're joined today by a hematologist, Dr. Lee Moseson from Sunnybrook Health Services Health Sciences Centre in Ontario. Dr. Moseson's research focuses on health services and outcome-based research on hematologic cancers, including the impact of patient-related factors on treatment outcomes. Welcome, Dr. Lee.
Thanks so much.
All right, so we unfortunately were also supposed to have our nurse specialist, Shannon Nixon, joining in from South Lake Regional Hospital in Ontario. Unfortunately, Shannon has been called in clinic today, and so she's unable to join us today, so we're going to miss her. But thankfully, she has actually sent in some of her responses, and we're also going to tap into Dr. Moseson to try and answer some of the questions that we would have been asking Shannon to answer. Okay, so I'm going to quickly pin all of our panelists so you can see them clearly. All right. Okay, so first of all, we want to deeply thank our panelists today. The session will be divided into two sections. The first will be a deep dive into barriers with accessing treatments in Canada, and the second section will discuss the unmet needs and challenges with the treatments themselves. I also want to get everyone acquainted with your screen on Zoom. You have a Q&A box, a question and answer box on your bottom half of the screen. If you have any questions for any of our panelists, please feel free to add your questions in there. We'll be taking these questions at the end of the session. So let's get started. Most of us feel fortunate to live in a country with a universal healthcare system. What some don't realize is that not all drugs or healthcare services are paid for by provincial healthcare systems, and we often only find this out when we need them the most. Each province follows its own provincial funding guidelines, and often there are either delays resulting in some therapies being accessible in one province and not in the other, or situations where a province will ultimately decide not to fund a drug for a particular lymphoma subtype. This is further compounded as newer and innovative therapies become available, potentially resulting in geographical or institutional restrictions or delays. We know that access to timely treatment is absolutely critical. This first section of the panel discussion will discuss the challenges and barriers people may have accessing treatments and provide recommendations on how to navigate the Canadian healthcare system. So with that, I'm going to start with Dr. Moseson. Could I tap into you and ask you, how do patients normally get access to standard of care treatments for their lymphoma following diagnosis, if indeed treatment is indicated?
Yeah, so it's a great question. There is a lot of regional variability between provinces, but for the most part, standard of care treatments are funded by each province. But it does vary within each province as to who actually funds these treatments. So I practice in Ontario, and in Ontario, Cancer Care Ontario, Ontario Health funds intravenous systemic treatments, so IV chemotherapies, whereas the Ontario Drug Benefit funds oral treatments. Whereas, for instance, from what I understand in British Columbia, it's the BC Cancer Agency that funds both IV chemotherapies as well as oral treatments by mouth. There are some challenges for some patients that require standard of care oral treatments in Ontario, because those treatments are covered for those that are 65 and older, or those up until including the age of 24, or those on social assistance. And so those that don't meet those criteria, often we seek help from private drug plans. And then there's also supplemental insurance that can be obtained, something that we call Trillium, and that's really based on income. But for the most part, I think standard of care treatments are quite consistent across Canada. It just may vary depending on what province you're in as to who actually funds those treatments.
Thank you. And I have a follow-up question for you on this. Are there delays in getting treatment schedules? Or if there are delays, what exactly is causing some of these delays?
Yeah, so in terms of the IV treatments, those that are standard of care, typically there aren't huge delays, as these would be standard of care readily available treatments. Sometimes there may be some delays in obtaining the oral treatments depending on how they're paid for in that particular province. And then in terms of sort of booking delays, that may vary based on the cancer center, just in terms of their volume. But I would say that certainly for patients that are particularly symptomatic, or patients that really do require urgent treatment, we try and have those patients treated in a more timely way, and often work both with nursing and scheduling to try and get these patients on treatment as soon as we can.
Thank you. Christina, I'd like to speak to you about your experience with accessing treatment at your local institution. How soon were you able to begin your treatment following diagnosis?
So when I was diagnosed, I was in my second year of university, and I didn't have a doctor at the time in the area. I'd only had my pediatrician, and then I just didn't have a family doctor yet while I was at school. So I was feeling very, very sick for months. And then I went to a walk-in clinic, and they just kind of ordered a blood test, and that was all over the place. My hemoglobin was really low. So then they told me to go to an urgent care center. This was before my diagnosis. And when I went there, they didn't really do anything. They kind of dismissed me, but they said the blood thing was a concern. So they got me an appointment with the hematologist. And the, I guess, closest appointment was 3 months from that time. So it was January till the end of March. And so in the meantime, I was just waiting, but I was feeling sick, like, you know, getting kind of sicker every day, really not feeling well. But by the time I went to the hematologist at the end of March, that day, the hematologist was super, super concerned and told me the next day to come back for a blood transfusion and, you know, more tests. And they had called my, you know, the hematologist was so kind to actually call my parents, who were in another town 3 hours away. But then that day, the day after I met with the hematologist, I had a pericardial effusion drained. I was admitted to the hospital, and then that night I wasn't doing well. So then they admitted me to the ICU after they took the biopsy. So the biopsy was Friday. By that Monday, I was still in the ICU, and then I started treatment, chemo treatment that day in the ICU. So by the time I got the diagnosis, it was right away. When the diagnosis came in on Monday, I had the treatment started right away, but it had taken so long to get that diagnosis that by that point I was really not feeling very well, and I wasn't really doing well at all. So yeah, that was my experience.
Thank you so much for sharing your experience, Christina. Dr. Moseson, I want to come back to you. We talked a little about standard of care treatments, but I want to really talk now about new novel therapies that are coming to Canada, either through clinical trials or following regulatory approvals. What are some of the challenges you see with your patients in accessing these new treatments where they may not be a standard of care therapy or other options available in that setting?
Yeah, so it's a great question. I would first like to say that drug access is incredibly complex, and as an oncologist, I can't even pretend to understand all of the intricacies. And so most centers have a drug navigator or a drug reimbursement specialist, some title to that effect, that really understands the processes in terms of accessing drugs, whether it's through private drug insurance or through compassionate access, so free drug from the actual pharmaceutical companies. But the process for newer drugs is a complex process, and I think some of the challenges are just in terms of how long that process takes. But indeed, it's a very rigorous process, given that we have a publicly funded system. The first step really is for Health Canada approval. So the drug company submits their drug to Health Canada, and then it's approved for that specific indication. That doesn't yet mean, though, that the drug is necessarily available yet, and importantly, not funded yet. And so the next sort of step to things is that then the drug company submits an application to a body called CADTH, which is a Canadian Agency for Drug and Technologies in Health. And essentially the process there is CADTH does an extensive review of that drug. It includes looking at the efficacy, so how well the drug works, comparing it to what are presently available in terms of standard of care, looking at toxicity, so side effects, and then importantly also doing an economic analysis. So seeing, is this drug going to be cost effective based on the evidence? And so this can take several months. And then following this report, it's then presented to an executive committee that then makes a recommendation. So is the drug, yes, should be funded? No. And if it is funded, does the cost of the drug need to be approved upon? And so this is a national body that was developed to try and make access to these treatments that are eventually funded fairly equal across provinces. And so once they make the recommendation, then it goes to the provinces essentially to negotiate drug prices. And they generally will follow these recommendations. So I think in terms of challenges, it's just a lengthy process, whereas our neighbors to the south, it's a bit more of a quick process once their equivalent of Health Canada, the FDA, approves drugs.
Thank you for that very in-depth review of the system in Canada, which can be a little convoluted, but I think also gives us, really gives us hope that there is due diligence that does occur at a very high level here in Canada as well. So Allison, I'd love to come back to you. Sorry, I want to get to you and ask you your experience with accessing treatment at your institution. Was this with a standard of care therapy or was it with new therapy? And before I get to you, I just want to quickly answer a question that I see in the Q&A. I know we're going to do Q&A questions at the end, but standard of care therapy really is just something that is not necessarily a novel treatment. It is what someone would be receiving as the standard treatment for that. So Allison, to you.
Sure. So I was relatively lucky compared to Christina in terms of I found a small lump in my breast, so I went to breast imaging at Princess Margaret, and they have a rapid diagnostic program. So I had a mammogram, an ultrasound, and a biopsy all in 45 minutes, head spinning. My family doctor informed me to let me know that it wasn't breast cancer, but it was a kind of non-Hodgkin lymphoma called follicular lymphoma. But she said I was lucky, it was good because it was slow growing and I may not even need treatment for a while. So I immediately went into problem solving mode and I researched follicular lymphoma, which I'd never heard of before. And I looked at prognosis and treatment options. So you get put into the queue for referral and staging. And as I went through this, I was still really hopeful that we caught it early. It was a small lump. I had no symptoms. I felt healthy. So I thought maybe I could have a little radiation and be done, or I'd be put on watch and wait and wouldn't need any treatment for several years. So I'd read up on all the possibilities and decided, best case scenario, that was going to work for me. So when I first met with the oncologist, I was really anxious and, sorry, Siri's interrupting me. And she said, we might not even treat you for 10 years. I was young and healthy and asymptomatic, so everyone assumed I would have a good prognosis. But once the scans were done, less than 2 months after my diagnosis, I was told that the lymphoma was extensive and bulky and I needed treatment immediately. So I was really shocked and disappointed. It was like a slap in the face to my positive outlook. And that day has really scarred me because I was so hopeful, and then it was like, boom, no, it's really bad. So 10, 11 days later, I reported to the chemo floor. And again, I'm really lucky. I live in Toronto with access to top cancer hospitals. So I would have been even more anxious if I'd had to wait for treatment, knowing that I needed treatment right away. So I was offered a preparing for chemo session at the hospital, but I opted to read the guide instead and prep myself and got there. And that was my first treatment. So I received standard of care, which was 6 cycles of bendamustine and rituximab. And then I did 2 years of rituximab maintenance.
Thank you so much, Allison, for sharing your story and your journey with us. So Dr. Moseson, I want to come back to you. You touched upon, IV versus, oral medications earlier, but what I want to ask you was, why aren't take-home cancer drugs funded for everybody? And what do patients do when they cannot get access to a funded drug? And I know you sort of touched upon it a little, but would love to get some more thoughts from you on this.
Yeah, so as I mentioned, there is some regional variability, so province to province. And speaking from experience practicing in Ontario, again, as I mentioned, it's fairly, I shouldn't say easy, but straightforward, I suppose, for those that are 65 and older, or those that are younger up until the age of 24, or those that are on social assistance. Certainly, private insurance is helpful, and then also compassionate access to drugs. And so one thing I didn't mention when I was speaking just a moment ago is often between the time of Health Canada approval to the time that CADTH sort of reviews all the drug, there are often compassionate programs available for patients, sort of as a bridge in a way until the drugs are hopefully funded. And then in Ontario, we do have a supplemental plan that's based on income called Trillium that patients can be enrolled in that does subsidize some of these drugs. But I agree, it most certainly is a challenge for many of our patients that aren't of that age or fortunate enough to have private coverage.
And so just as a follow-up, do you have any recommendations or supports that you would recommend for patients who are trying to navigate this and want to understand how they can facilitate more timely access? Who do they go to? Who do they speak to? What should their first steps be?
Yeah, so certainly speaking to your healthcare team, so the nurses, the oncologists, social workers can be helpful in that regard, particularly if you have to be enrolled in a supplemental funding program like Trillium in Ontario, for example. And then, as I said before, I'm not sure what I would do without a drug reimbursement specialist or drug navigator to help understand the landscape and what's required to access compassionate drugs, what's required to access funding through private insurance. And so relying on them is incredibly helpful, and I think a good start for patients as well. And most centers will have such individuals available. I don't think that we would function so well without them, to be honest.
Thank you for taking us through that. And I also want to, at this point, talk about some of the work that Lymphoma Canada does in this space as well, with respect to advocating for access to treatments for patients who, are looking for some of these novel therapies coming into Canada as well. So that was really our first section where we wanted to really talk about accessing treatments. And so thank you to our panelists for this particular section. And we really hope that the section discussion sheds some light on the challenges with accessing treatments in Canada and ways to navigate the healthcare landscape to reduce the burden and delays for patients. The next section now will discuss specific challenges that patients may experience while receiving their treatment or following their treatment, and what resources and supports may be available to them. Not only can there be challenges to receiving treatment, such as the frequency of appointments, and especially things like travel and mobility can also be a barrier, or side effects related to treatment, but it's also important to recognize and acknowledge that treatments can impact a person's quality of life and ability to continue with daily activities. And so we would like to hear from our panelists on what challenges they faced and what they wished was available to them to address these unmet needs. So Christina, I'm going to go to you first. as a lymphoma survivor, having been diagnosed and treated at a young age, what was your experience with the therapies you received, and what were some of the challenges? You know, were there specific challenges with respect to any special precautions or procedures or side effects? And how were you able to manage your daily commitments and tasks?
In terms of precautions, when I was in the ICU and about to start treatment, I had an obstetrician gynecologist come to talk to me to discuss fertility preservation, but at the same time, it wasn't an option that was available to me because the nearest place was in Ottawa, and it would take several weeks that would delay the treatment, and I didn't have that option. I didn't have time for that, so that was a discussion. And I've known now many young women who've also had different types of chemo, different types of cancers, and that's a concern with all younger women. I think especially people who probably haven't had children, that's a concern, and I didn't have an option to address that. And it wasn't actually even addressed later on after my treatment, when it still could have been maybe discussing fertility preservation. There was still nothing at the time available to me, and nothing that we had discussed. So that's why there's actually a really good webinar available on Lymphoma Canada, and I encourage all young cancer patients to listen to it, talking about fertility preservation and sexual health. In terms of the immediate issues, I had a PICC line put in to receive my treatment, and I actually developed a blood clot from that. So they switched the arm, but then they needed to start me on blood thinners. And I think blood thinners are generally, even if you see the commercials, blood thinners are generally given to people of a much older age, especially maybe primarily men, not like menstruating young people. So I kind of thought, I'll be okay. But then the first menstrual period I had after starting the blood thinners, and this is while I was doing my chemo and everything else, I bled so much that I had passed out. And so then I had to start at the time birth control to counteract the effects of the blood thinner medication. And then after that, through the chemo, I lost my hair. So I had the physical side effects, and I also gained weight and had an extremely swollen face, extremely swollen neck from all the steroids and other medications. And then in the longer term, just a few years ago, so around 4 to 5 years after my treatment, I developed hypothyroidism from the radiation that I'd had to my neck. And so that was kind of, what I was dealing with at the time, and still kind of ongoing. And in terms of how I was dealing with everything else, I was in school at the time. So it was March, right before my exams in April, and I was in the hospital for several weeks, so I couldn't attend my exams. So I had to contact the school and get them to give me what was called aggregate standing. So get the credit for the course without finishing all the work. And then I was basically at home, and I just started doing online courses. But at the time, I was very lucky to have the support of my parents, so I could continue on with school. And, they were actually paying for my education, which I'm really grateful for. So I was able to just kind of continue. But otherwise, at the time, I couldn't work, and I was feeling very ill. So I would not have been able to pay for my school and continue if I hadn't had that support. So that was what my experience was like.
Thank you so much, Christina, for sharing your experiences with us. And you're so right about having those support systems in place, which I think is incredibly important and critical as well. So Dr. Moseson, I'm going to come back to you and ask you this similar question, but from the side of a healthcare provider. For younger patients diagnosed with lymphoma, what are some of the considerations that are key that they should be aware of when going through treatment, and what resources and supports can you direct them to?
Yeah, so it's a great question, and I think Christina discussed quite a number of these, but certainly for our younger patients, there's no doubt about it, it's a life-altering diagnosis, and many of our younger patients are entirely fit and healthy before their diagnosis, in the months before, and so it's absolutely life-altering. And so we recognize that there are a lot of challenges really for any patient with lymphoma, but for our younger patients, there may be issues with being able to work through treatment, being able to continue with school. And so social work involvement is really important, and something that we try to do for most, if not all of our younger patients, even if they don't need it perhaps at the time of diagnosis, at least they have that contact available should there be issues that arise, whether they need time off of school or if they're working, whether we need to help with short-term disability or long-term disability letters and applications. And so social work is very important. Also fertility preservation, and as Christina mentioned, sometimes that's quite challenging, particularly for our younger female patients, because that process can take some time, and some of our patients are so sick that we have to balance the risk of infertility with the treatment of the lymphoma, and that can be particularly tough. Although there are some other strategies like suppressing menstruation that may have some benefit there, but certainly something to discuss at the first visit with the oncologist, because sometimes, again, these can take a few weeks, and there may be a few weeks when you're waiting for scans and other things to happen when the fertility preservation discussions can occur. And then certainly to discuss it again at the end of treatment to see how things are going. And then certainly resources on Lymphoma Canada in terms of sexual health and body imaging, and also social networking, how to discuss with friends and colleagues and family members as well is a really good resource. Some centers, and there's typically larger centers, they often will also have adult or young, or adolescent or young adult sort of programs that can assist with some of these challenges, but those are often limited to sort of the very big cancer centers.
Thank you for outlining some of these fantastic resources and supports. Alison, I want to come to you. As a lymphoma patient diagnosed at a busy time in your life, what was your experience like, and how did you manage your treatment with your daily commitments and tasks, and what resources were you provided to assist you while going through treatment?
Yeah, so my oncologist told me it was okay to keep working during treatment, and I had 2 teenagers living at home at the time, so I wanted to keep my life and my kids' life as normal as possible. So my employer was amazingly supportive. I was given complete flexibility to take off whatever time I needed. So for the first 4 months, I took treatment days off, Monday and Tuesday, and then I worked from home for the rest of the week. But by the 5th cycle, my fatigue was getting worse, so I took the rest of the week off. But the following Monday, I was back in the office or at the client. So the main effect was that I wasn't really taking the best care of myself. I thought I was managing 2 client engagements. I was driving hockey carpool, exercising, continuing my busy life. But the week of my first cycle of treatment, I attended a large family party in Montreal the following weekend. The week of my second cycle, I hosted a dinner party because it was already scheduled. The week of my 4th cycle, I flew to Vancouver with my daughter to move her into residence for her first year of university. So I just kept going and doing everything as much as I could while doing treatment and feeling worse and worse. So it was about a year after my diagnosis that I really started to feel like the wheels were coming off. When I was in maintenance, I sought out psychosocial support and was connected to this amazing social worker at the cancer center. And I had regular meetings with her, and she really gradually helped me to accept my new normal. Then I also joined a mindfulness-based cognitive therapy program, and that really helped me to manage my stress and anxiety. But I was still working and living at a frantic pace, and my fatigue continued to get worse, to the point that I'd come out of a client meeting and sit in my car and have to just rest before I could drive home. I also have a few little dings on my car, from probably shouldn't have been driving. So eventually, actually the week after I completed my 2.5 years of treatment, I realized that I really need to take some time off. So I went to my family doctor, and she completely agreed, was surprised I was still working, and asked me how long I needed. And I said, oh, probably a month. She goes, let's start with 3 to 6 and see how it goes. So I was referred to around this time too, I was referred to the Cancer Rehab Survivorship Program at Princess Margaret. And coincidentally, this program was founded and is run by a doctor who was himself a blood cancer survivor. So that gave me even more confidence in the program that they would get it. So it's an amazing program. It's funded by Princess Margaret Foundation. And it includes fatigue, managing emotions, mindfulness and relaxation, diet and exercise, mindful eating, brain health. and the importance of being connected. So I really enjoyed the session on nutrition because they have a nutritionist, and there's also, the program has their own resident chef. And we did a little cooking class. So it also includes a weekly exercise component, and each patient is provided with a customized exercise program. What I realized is most cancer survivors are encouraged to be more active, get up and walk every day. Many have never exercised before. I was the opposite. I was told I needed to moderate my activity and give my body time to recover. I need to do less than what I had been doing. So around this time, my oncologist could also see that I was still anxious and suggested I may need some more psychosocial support. So I started to see the psychiatrist, and as luck would have it, the fabulous doctor who ran the mindfulness-based cognitive therapy program is also the psychiatrist who supports the hematology team. So I was already familiar with her and was able to open up quickly. So much of my sense of being was tied up in my active lifestyle and my demanding career. It really took a lot of work to adjust to my new normal and my expectations of myself, really. But tapping into all these resources was a process of time over more than 2 years. So I definitely know that I'm stronger for it, and I'm grateful to all the amazing people at Princess Margaret who helped me support throughout. But yeah, it was a process. It wasn't that I knew what to do as I was going. It was tapping into stuff as I felt I needed it, or probably a little after I needed it.
Thank you, Allison, for sharing your experience and your journey, and also amplifying some of the incredible programs that are available for others who might be going through the exact same thing right now as well. And you're so right in saying that it is actually a process. And so you have to get to it as and when you need these support systems, but they do exist. And I think it's great that we're actually talking about this today, so everyone is also aware of such incredible programs within their institutions. So Dr. Moseson, I want to come back to you. Treatment side effects can be very challenging for patients, especially when they experience these side effects long-term or if they appear many years after treatment completion. What are some of the more common long-term side effects that you've seen that your patients have experienced, and what are some management options and techniques?
Yeah, so I mean, I think that there are some longer term side effects that may be specific to the particular treatment that was received. So for instance, some of the standard treatments that we might use for aggressive non-Hodgkin lymphoma or Hodgkin lymphoma can result in numbness and tingling in the fingers or toes, something that we call peripheral neuropathy. And sometimes it requires adjustment of the dose throughout treatment, but sometimes these symptoms can actually persist even after the treatment's done. They sometimes get better, and sometimes, unfortunately, they don't. And so just recognizing that and to know that there are some available medications that may help to alleviate some of these symptoms if they're particularly bothersome. And then there are other longer term side effects that may not be specific for that particular treatment, but just by virtue of the fact of having this life-altering diagnosis and receiving treatment. So for instance, fatigue, as Allison discussed, can persist for quite a long time. Often patients might think, oh, I'm done chemotherapy, I'm going to feel great the next week, but it can take 6 months, even 12 months for some patients. But I think it's important to know that there are resources and supports available, as was discussed, and also to continue to try and be physically active. And there we're not, necessarily referring to, vigorous exercise, but just going for walks on a regular basis, for example. And, healthy, well-balanced eating can help with that as well. And also something that we call chemo brain can happen as well, where patients experience sort of a clouding of their ability to process things cognitively, whether it's maybe just a little bit in the way of memory or just thinking more clearly. And that happens not uncommonly on treatment. So just understanding that is something common that can happen and does take some time to get better, but also to discuss with the healthcare team to make sure that there may not be another reason for experiencing that. And then, many other things we could discuss. But lastly, the thing that I think is also very important is that even after treatment is done, at that point, many patients may experience anxiety or sadness that may result in depression, particularly related to fear of disease recurrence. and just to understand that this is actually something I think that's very common, and I think it's really quite under-recognized, and that there are supports in place, and important to talk with the healthcare team as there may be referrals to psychosocial oncology, whether that's social workers or psychiatrists or psychologists. And that's an area I'm actually particularly interested in, and we're trying to study that to try and better understand how patients cope following completion of their treatment.
Thank you for that. Allison, I have two questions for you. One of them is, did you experience any long-term treatment-related side effects, and what has worked for you to cope and manage them? And in fact, I'm going to add in an audience question as well, because it ties in really well. But an audience question has come in asking, what is now your new normal? What does it look like? So I'll let you address both of them.
Sorry, Allison, you're muted.
So that's okay. Okay, so my most enduring side effect I experienced was fatigue. Some people have described treatment-related fatigue as feeling like you're weighed down by an invisible backpack. I describe my fatigue as feeling like my face is weighted down. I just felt like this heaviness on my face all the time. And I worked so hard to improve my fatigue and to keep working and to keep fighting. But after the mindfulness-based cognitive therapy program and the cancer survivor rehab program, and walking and exercising and eating right and napping and yoga and meditation and counseling sessions, I eventually learned that I cannot fix the fatigue. So I had to learn to manage it, which ultimately meant I had to manage my expectations. So I've discussed my fatigue with my family doctor and my oncologist many times. When it was detected that my iron levels were really low, my hematologist was excited because she thought she had solved my fatigue issue. Unfortunately, even after infusions to raise my iron levels, my fatigue persists. So there's no known studies on long-term treatment for treatment-related fatigue, and I would gladly sign up for the one if there were. Realistically, fatigue is a minor side effect compared to, a heart condition or something. So, but I've connected with other patients. There's a follicular lymphoma Facebook group that's helped me to know that I'm not alone. A lot of people suffer from long-term fatigue. I've now been off work for almost 3 years, and I don't have any prospects of returning to the job that I loved. But I've learned to live with this limitation and prioritize my activities and still live a good life. So my new normal is I have 4 or 5 hours of what I call active energy in a day. And I need to prioritize things during the day to do the things that I need to do or want to do during the day. And then I need to accept that I have downtime. And I need to accept that Netflix is my friend, and because sometimes even reading a book, I can't get through. If I start reading, I lose track of where I am and I just need to stop. So COVID actually wasn't really a huge change for me, except that I couldn't meet friends for lunch or coffee. I was home and I was doing a lot less. So a lot of people struggled with COVID because they couldn't do as much, and I was already there. It'd take me a couple of years to get there, but I was super busy, and I'm a lot less busy now. But I still try to do the things that are important to me. Pre-COVID, I was traveling. I see friends. I try to keep busy. Thankfully, I have a dog. I walk my dog a lot. But yeah, my new normal is just a lot slower pace.
Thank you for sharing that. So managing expectations, prioritizing what is important to you. I think these are all really great reminders for all of us, in fact. So thank you so much for sharing. Dr. Moseson, I'm going to come back to you and ask you, with the patients that you work with, what are some of the impacts on quality of life specifically, and what are the resources and supports or coping mechanisms that patients have used with success?
So yeah, so I think there are a number of things. So certainly throughout treatment, one's diet and nutrition may be impacted. A lot of centers will have dietitians or nutrition resource centers that can provide really valuable information about strategies to try and improve diet and oral intake. Physical activity as well, as I mentioned, I think is really important. I think trying to be physically active while on treatment helps both in terms of tolerating the treatment, and I think also maybe help for mindfulness. And again, physical activity doesn't mean, running vigorously on a treadmill 30 minutes multiple times a week, but even just going for walks can be really, really helpful for some people. And often we'll hear from patients that their sleep may be affected as well. And so mindfulness and relaxation techniques, some people like certain apps that may help with that, can be quite helpful for sleeping. And then certainly support groups, because as an oncologist, truthfully, we don't know what patients are necessarily going through. And I think hearing from other patients that have maybe had similar experiences can be both validating and also important to understand what strategies they may have used to overcome some of these challenges, including psychosocial support at the particular cancer center.
Thank you for outlining these fantastic resources and supports. Christina, I want to come to you and I want to ask you, what were some of the unmet needs or challenges that you experienced through your cancer journey? And do you have any suggestions for what we can improve on and what we can actually work on to, to improve the experience at the patient level?
I think it's really important to kind of connect young people. I think it's just interesting that he just mentioned that, they don't really know what you're going through. Because, I mean, when I was sick and it was really hard when you're young also because, your parents are so stressed and worried, and your family and people haven't, at least in my family, hadn't been through something like that. So, I was always being very optimistic around all my family and friends, always had a smile on. I was just like, go, go, go. I don't think I ever cried once in front of anyone in my family, but like emotionally on my own, I felt kind of very alone. And actually the hardest part for me was probably not this 7 months of my treatment when I had 6 rounds of chemotherapy and then 20 days of radiation. But so that part on its own, you kind of just go, go, go. And then when you're done, you kind of expect to feel like a huge sense of relief. And I think, you kind of feel a little bit happy that you're not going to have any more treatments, but I think that's actually when it got the hardest, because people kind of thought, oh, you're good, you're done your treatments now, things should be good, you can just like move on. And it might look like I did to my family and friends, but on the inside, I was, when I went back to school, I was feeling very like alienated. I just felt like nobody could understand what I was going through. In my mind, I thought that was really challenging. And I also had, fatigue, which it's kind of hard to even like explain that. Like it took me about a year and then I felt better, but I still didn't feel the same way. And I still haven't gone back to some of the things I did when I was, 19 beforehand. And I did half marathons and stuff like that, but I hadn't been able to get back into running. So I think it can be really isolating because a lot of people at that point haven't gone through something like that. By the time you're my age, even now, even at 27, now I know a lot of people who have had cancer themselves or have had a parent or family member go through it. But at that time, it was much more isolating for me at age 20. So the social issues, that's kind of a challenge. And I do know, like he mentioned, many of the main cancer centers, the bigger places, have ways to connect the young people. And I think that's really, really important. And there are other organizations too that can do it. And Lymphoma Canada now has resources on their website, but I think young people getting connected with each other is important because, when you're at chemo and every single person in there, it feels like they're 30 to 60 years older than you. It's a kind of a very weird feeling, and it makes you feel even more isolated. So that was a challenge. The fertility preservation, I think following up is kind of a challenge because, once you're better, where does it fall, right? Is it the family doctor who should kind of follow up? Is it the patient themselves? Is, the hematologist and the radiation oncologist, they're all, they all have their own piece. So where does kind of like the longer term follow-up happen in terms of my, hypothyroidism? It wasn't like I was told, okay, you should be looking for this and monitoring it. It was only once I started feeling really sick and then got a blood test and kind of investigated that was discovered. So I think the post-treatment education and a plan is kind of important, and how to manage that is, a difficulty on its own. Like, yeah, I got some really good advice from someone at Lymphoma Canada who said, you know, they tell all the patients to have like a binder of all of their stuff and to bring it to their doctors and kind of say, this is what happened, this is what I received, what should I do? And I think that's kind of important. So like longer term testing and monitoring, post-treatment, kind of what to look out for, fertility preservation, and then, yeah, the social support. So I think, you know, young people getting connected with other people, whether that's through like a charity or just like finding people who've had a similar experience to you, or reading like patient testimonials on Lymphoma Canada's website. I think all of that's important.
Thank you. So like the idea of it actually being a very holistic view of not just short term, but long term, not just physical, but emotional and social, the entirety of that is just so incredibly important. So thank you for sharing. Allison, I'm going to leave you with the last word on this question. And it's the same question that I'm going to pose to you as well. What were some of the unmet needs or challenges that you experienced through your cancer journey, and what suggestions do you have to improve this?
So at some point, I was given several brochures, a stack of brochures about all the different supports that were available. And I think I may have picked up some myself from the patient library or a display at the clinic, but I was so focused on getting through treatment that I didn't really pay attention. I filed them away. So it was probably more than a year after I completed treatment that I opened that folder and found all the different resources that I had tapped into over the years to help me cope. They were all there in the pamphlets, but I hadn't really referenced them because I got them at a time where I couldn't focus on that stuff. I was just like, okay, just get through chemo and you're good. I was always looking for someone like me who, like Christina, I was always looking for someone who was like me, who was going through what I was going through. So I joined that Facebook group for follicular lymphoma patients. I signed up for peer counseling. I looked around the clinic waiting room, same thing. They're all 30 years older than I was. So I realized that everyone's experience is different and we all need different supports at different times. And I'm, again, really lucky that I live in a major Canadian center. There's plenty of resources available, but I'm a resourceful person. So I connected with those supports when I felt I needed them. I still had to do it. And so no one was spoon feeding me or holding my hand. I had to find those resources that I needed when I needed them. And that's a big piece. Not everybody's really great at advocating for themselves. So if you're not, then you need somebody who will. I'm pretty independent and it's really hard for me to ask for help. My sister acted as my chemo buddy. So she brought snacks and trashy magazines for us to read during chemo, knew where to get the warmest blanket. It's at the bottom of the stack, drove me home after long treatment days. And you will need help. And I probably didn't ask for help enough. And I probably pushed myself too hard, but that was my way of coping. So my biggest advice to people is ask for help, take breaks and take care of yourself, because it's a marathon. It's not a sprint. I've said many times too, especially in the insurance company, but I have an incurable lymphoma. So I know that at some point I'm most likely going to need treatment again. So my focus has been taking care of my health. Eventually I started taking care of my mental health, and that has really helped me get to where I am. And those supports, they are out there. It might be harder if you're not in a large center, but like Wellspring has a virtual support. There's a lot of things that even people outside of the big centers can tap into. But you do have to do it for yourself. Nobody's going to hand it to you and tell you when you need what.
Yeah. So, you know, brochures and first sheets, social media, peer groups, counseling. But as you mentioned, we really need to do a much better job of bringing these support systems to people. You can have a fantastic program, but it's only as good if people are actually aware of their existence. And so thank you for highlighting these barriers that exist with accessing programs such as this. And absolutely, you know, asking for help, taking breaks, being kind to yourself. These are all incredibly important as well. So I think this is going to probably wrap up the panel session, the questions that I had for the panelists. So what I'm going to try and do is actually bring in some Q&A from the audience. So the first question, and I'll open this up to anyone, but I'm assuming this is probably the question that Dr. Moseson might have some info on. What do I do as a patient when CAR-T or other treatments are not available in my province? Why does this happen where some Canadians have treatments available to them and others don't?
Yeah, it's a great question. On the topic of CAR-T therapy, it's a very specialized therapy and needs to be given at a very experienced center that can both manufacture the CAR T cells and also administer them, and being able to monitor for complications. And so up until actually quite recently, we were actually having to send patients to the United States for this treatment. It was paid for, at least in Ontario, by the Ontario government, but now we're fortunate that we do have centers that are able to provide this treatment. For provinces that don't have access to this treatment in that particular province, they're often referred to other provinces specifically for CAR T therapy. So I know here in Ontario, for instance, at Princess Margaret Hospital, they may receive referrals from patients where they don't have that particular treatment available in their center in that province, and then it's often paid for by the home province.
Thank you. The next question is there any effort being put forth to simplify the Ontario Trillium Drug Benefit Program, as the future for CLL therapies or medication and the current system is so complicated and overwhelming? And plus, most people end up paying out of pocket for cancer treatments, which most Canadians do not realize.
Yeah, so I'm not sure I can answer that. I think that might be a better question for, a drug reimbursement specialist, or perhaps a bureaucrat that's involved in administering these programs. But I agree. I think that drug access for some patients is challenging, and there are some treatments where patients unfortunately do pay out of pocket, and we try our best to get compassionate drugs, but for some patients it's just not affordable, and that's not an equitable way. And so it's really frustrating, certainly as a oncologist, that we don't have access to some of these treatments for some patients, but certainly things being more streamlined would be incredibly helpful, at the very least, to try and better understand maybe what some of these barriers are.
Yeah, I think the streamlining, especially, not just for improving efficiencies, but for equity, is so critical. And so hopefully someone is listening to our panel today and taking notes on how we can actually make the system better for patients across Canada. Okay, the next question is, so I always struggle saying this word, so I'm going to butcher it, Dr. Moses, and you're going to have to correct me. My new normal from my diagnosis and treatment of follicular lymphoma has a new normal of hypogammaglobulinemia, there you go, which has meant living in a COVID safety plan far before COVID. Any research that is being done in this area, or ways of living with this?
Yeah, so in terms of sort of treatment or management strategies, so I think what the questioner is referring to is hypogammaglobulinemia, which essentially can sometimes happen after treatments where what we call immunoglobulins or antibody levels are low. And so that renders patients at an increased risk of infections, certain kinds of infections. And so in terms of management strategies for patients that have low antibody levels and are experiencing frequent infections, we often will replace the antibodies. So something that we call IVIG, or intravenous, so IV immunoglobulins, we replace the antibodies, or another form which is subcutaneous, so an injection under the skin that patients are able to administer at home, which I think is better for one's quality of life, not having to come to a center to receive this treatment. And that helps to try and protect patients against severe infections. And so that's sort of the management strategy that we use. Unfortunately, some of that is unavoidable in terms of having low antibody levels, either by virtue of the lymphoma itself or from the treatment.
Thank you. And so this question that I'm going to ask next actually is something that we have discussed in the past and on this panel in the last couple of years, but we didn't specifically refer to it today, but it's a great question, and it has to do with getting second opinions. And so we have a question here about why was my medical oncologist unwilling to refer to another hospital for a second opinion, and what really are patients' rights surrounding this?
Yeah, so I can answer, and then I'm not sure if Allison or Christina maybe has a different perspective from a patient. But from my perspective, I think that everyone should be entitled to a second opinion. I think it's important that patients and families are comfortable with both the diagnosis as well as the treatment plan. And so, as an oncologist, certainly if a patient approached me and asked for a second opinion, I would certainly facilitate that. Sometimes there may be challenges in that some of the larger cancer centers are less likely to see patients for second opinions. So it may not be the center of choice where a patient would like to have a second opinion, but certainly we try our best to facilitate. And I think it's really important because you want to have the utmost confidence, again, both in the diagnosis and also the treatment plan.
Okay, thank you for that. So I think we only have time for one last question. And Christine, I'm going to pose this to you. We talked a little about what Allison's new normal is. And the question to you is, what is Christina's current life experience? And you're muted, Christina.
Oh, yeah. Well, what I ended up doing so I was in school, so I did online courses to finish that semester. And then for me, it was really important. It was just a goal that kind of like motivated me to graduate on time with my class. So I finished up the rest of those 8 months. Instead of going back to school, I just did online courses for that year. I was supposed to go on exchange that fall, but it got pushed back to the next year. So I ended up still going on the exchange that I was supposed to go on that September, when I ended up still being in treatment. And then on that exchange, I met what's now my current husband. And then we got married in 2018. Now we've been married for 3 years, and I've been working full-time as a business development manager. So, I mean, things are pretty good for me now. We're at like a point in our life where now, and it's going to be soon 8 years after treatment. So I have I take Synthroid for my thyroid problem, and next year I'm going to start getting like regular, I guess there's a mammogram that I need to do because I had radiation to my chest, and then some other things. But my radiation oncologist is really good at following up with that with me. He still sees me on a yearly basis, even though after 5 years, I guess they normally don't see you anymore, but he's still been seeing me on a once-a-year basis. And we don't have any children, but I would like to have a child. So we'll see what happens and if that's possible. So yeah, that's what's going on with me.
It's amazing. Thank you so much for sharing that. So I would like to take a moment to thank our incredible panelists today for this fantastic discussion that we've had. Thank you for sharing your stories, your personal experiences, your expertise. Really, really grateful to all three of you here today. Our audience learned of the many issues and challenges facing lymphoma patients related to treatment, and also some potential management and coping techniques that might actually help them through their journeys. So, and we'd also like to thank our audience for attending and asking questions. I know there were quite a few questions that we were not able to get to, so please contact us at info@lymphoma.ca. I'm going to have my colleague put that in the chat box now, info@lymphoma.ca, and please send us your questions. We'll try and address them after today's panel.